So this is really the last paper in the series that you could see either as an international policy brief or a challenge, a bringing together of the elements that we need to tackle together. So these are the authors, again, quite a few of us in the room. And we've seen what quality maternal newborn care is. I think Mary's given a very beautiful description of what it is we really should be providing women based on what they need and what they would want themselves. We've seen from Caroline what they can do and how when we scale up the numbers of midwives, but also their effectiveness, their quality, their capacity to provide services correctly, as Wim has been saying, what the impact of that can be. And then we've heard from Wim how important the need is for health systems that actually allow people to provide that quality kind of care and not just midwives. That goes for all of us. So I think that trying to look at that and you know, why? So what? So we've got all that sorted out, then what's the next thing? And I think the important thing that we need to remember here is that we are investing in people. This is what it's about. It's investing in people, not only those who provide care, but also those who receive care, those who work in communities and who work closer to women in facilities. We want to really understand and be able to support the fact that what a woman wants, not from our technical perspective, but what she sees in her way, in her part of her life, is she wants health, she wants safety, she wants support, and she wants a healthy child. Those are the things that count for her. We're providing everything, and we're trying to provide everything that goes beneath us, to make that available for her. The important thing that we then need to do is how can we support these women to get access to these kinds of services, to these kinds of midwifery services that meet their needs, and how can we increase the quality of that care. So those are proactive and substantial changes that are needed. We're not saying here in front of you, this is going to be quick and we'll do it very fast for you. So the investing in health, investing in women, and the women-centred elements, and I've not put words on this per slide for you, I've just put images because I think these are the three things that meld together from our presentations, that meld together from these 3+ years of research that we've been doing on this. And we really want to invest together for midwives, for women, for children, for the world, for the best resource there is in this world, which are people. And we invest and we do that through people-centred care that's equitable, that has high quality, that is safe and respectful. And we do that as well through women-focused care. Putting their needs at the centre completely changes our perspective. There are models out there that are called centering pregnancy or group antenatal care that turn our way of thinking upside down, that turn my way of thinking as a midwife upside down, because I'm no longer looking at the world from where I am trying to make everything safe. I'm looking at it from where the woman sits and what she needs and what she wants. So that's what we have tried to set out in this paper, in a way that will give people opportunity at every level where they are in their system, in their world, in their culture, to work with that, to find the elements that will help them make the changes that they need specifically. And we're then looking at effective coverage, which is the combination of the numbers of people that we need, but also the quality of care that they need to be providing in the work through their workforce. So the numbers of people that we need as doctors, as midwives, as nurses, and also the facilities that need to be available, midwife-led units close to secondary, tertiary levels facilities that provide quality care, that have the opportunity to shorten the delays, to shorten in areas where transportation and communication are complicated, the things that women have to go through to try to get to that care that they need so badly. We're looking then, of course, at numbers of providers who are available, accessible, and provide acceptable care. The AAAQ that we've used extensively in the last couple of months, years, working into State of the World's Midwifery 2014 as well. And that quality care works on 3 levels. We need that to be at the technical level, the competencies of our providers, the quality of our facilities, at the organisational level, as we've heard, how the health system works, how people can gain the access that they need, and at the interpersonal level. And we've got in this series the tools to test all 3. And I think those are really going to be crucial as we move forward to providing what we should and what we want to provide, because I know that all of our hearts are in this and we want this to work. So people know quality. They know as individuals, they know what quality is, or they feel what quality is. They talk to each other. They say, oh, there's a good midwife there, or there's a great facility there. There's a doctor there who really gets this, or who's really into this kind of level of support, and who's providing, who understands who we are and what we need. And I think that those are telltale signs that will tell us, and that women can know for themselves. And research shows that they will bypass a facility where they don't find quality. And that's not only because of the provider, it's also because of delays, or because of facilities not being well stocked, for things not being available to them. And people have often, we've taken an approach over the past couple of years, as Wim was also saying, to looking at the technical interventions. We now have the quality maternal care framework that really shows us what else is needed, the additional pieces that are going to make a massive difference. We have the evidence for their impact, and we need to put those two together. We need to give everybody the opportunity, all of the people that provide this kind of care, to find the areas where that interacts best in their communities and best in their societies. And putting that together really kind of gives us the policy brief that this last paper in the series is. Needing collaborative practice, working together from household to hospital, each of us working to the full scope of our practice, not trying to not overlap, so that we do the most cost effective that we can be. And in this paper you will find a set of pragmatic steps of getting there. It gives you steps that that you can pick up separately, you can use in sequence, you can turn the sequence around, but that really give people food for thought about, so how does that work in my area? Have we got the education of midwives? Have we got the education of doctors and nurses together enough so that they understand each other's practice and can really function together as a team? Have we got enough regulations so that people can work to their full scope of their practice and are not kind of held back because of legal problems, which really can be sorted very easily if we have an open mind and we find a way to do that together. So the paper also does then still find some areas that need some more work, and I think every paper has highlighted which the ones are that are most important for the piece that they're working on. And one of the ones, and I know it's being worked on, and there are colleagues here in the room who are active on that and have a meeting on it tomorrow, is a dynamic benchmark to support the system and workforce planning. So how many people do you need to provide a certain amount of care? We need to be able to say, in this kind of a situation or in this kind of a setting, either in a rural area, in a peri-urban area, in an urban area, we need to be able, for midwives, for nurses, for doctors, to provide care collaboratively, and so many women, so many pregnancies, so many care cases per provider. We also need to see what productivity can be reached. We have a piece in the paper on improving maternal and newborn health through midwifery that says that midwives are not working to the max of their capacity. If their capacity were to be 175 births, they would, on the other hand, only be able to do the births. They wouldn't be able to do anything else around that. And those both are very situations in which we're not cost effective and efficient. And I think there's a lot we can do about that, and we can make that a lot stronger. And then finally, as Wim has already said, and I won't go over that again, we really need to understand the impact of and the breadth of complications that the commercialisation brings, and the inequalities that brings as well. If you have money, you can access care. If you don't, you can't. And that's just not right. That's not about investing in people. So if we look at the impact, Caroline has written out in her paper that a lot of what we see, how many lives can be saved. And lives being saved is really what we're looking at in the global arena. I've given you a couple of the images of all the plans and the post-2015 discussion, every newborn action plan, the MDGs that we've been working on for almost 15 years, the ICPD, the Rio +10, loads and loads of big things happening. And discussions that we have to have not only at this global level but also at regional and national levels. Without the discussions at regional and national levels, these global plans are not going to happen. But without quality maternal newborn care, as described in our series and as supported through midwifery care and by midwives and others, it's not going to happen either. Mary ended on saying midwifery is pivotal. I think midwifery is pivotal to national situations, but definitely also to achieving these plans. And with an audience where so many of us are interested in this area and where so many of us are working towards making these goals achievable and finding a way to get to universal health coverage post-2015, we need to really take on board the core contribution that happens when you provide and you invest in pregnancy, childbirth, pre-pregnancy, post-childbirth, early years of life for a healthy mother and a healthy child. So I think that we have the majority of the areas that we've been looking at covered in this series. We have a lot of other pieces that still need to be done, and there are 2 more papers that are going to be working on this. We have a human rights piece that we need to very much more focus on, and we have a research agenda we want to detail. But really, to just leave you with this last quote, that this is the way we think that we can go forward together. Political will and commitment are increasing, contrary to what Wim just said, and I think that people are picking up on what the real value is of what can happen. It's not the first thing, but it's picking up now. Women's, families, girls' voices are very, very loud. We hear them a lot. Economic growth is picking up. Africa is obviously going to be our next area of big progress, and specifically with our opportunities to combine education and health and economic growth. I think there is a lot we can do. We can do that together, and we should do that right now. Thank you.